So welcome, Professor Kenneth Tomecki. Thank you very much for your excellent lecture. So you spoke about non-TB mycobacterial diseases,
Correct.
Is that right? So can you just summarize your lecture in a few points?
Summarize a 30-minute lecture in a few points, in 3 minutes or less. That is
Go for
rather
it. Go for
heroic
it.
and ambitious, but I shall try. The mycobacterial organisms are indeed the third or fourth cousin of all mycobacteria. We think of tuberculosis, we think of leprosy, but we really don't think much about the non-TB organisms, but they're actually very important. And to dermatologists, there are probably 3 organisms that are very important. Number 1 is M. marinum, the organism that produces fish tank granuloma or swimming pool granuloma. It's a slow-growing organism, but it's a photochromogenic organism, so on culture it produces pigments. So for the microbiologist, it's rather distinctive. To the pathologist, it can be distinctive, and to the clinician, it's very distinctive because it produces a papule, a plaque, a nodule, often in a sporotrichoid appearance on the hand, up the forearm, and it's rather characteristic, but it often takes a long time, several months, for the actual exact diagnosis to meet fruition, sometimes 4, 5, 6 months. Treatment is with oral antibiotics, sometimes surgery in concert as well, if disease has invaded underlying tissue to produce an osteomyelitis or a tenosynovitis. It's a refreshing diagnosis to make because you can be the hero or the heroine and can turn the life around for the patient. The other organism of note would be M. ulcerans. M. ulcerans, also known as the Buruli ulcer, discovered in Australia 30, 40 years ago, but it takes the name Buruli from the district in Uganda, which gave it its name, because most of the cases are found in Africa. And this produces a huge, rather horrific, asymptomatic ulcer, usually on the trunk, sometimes the extremities, in a youngster or a young adult, but completely asymptomatic. Rather distinctive disease. Biopsy will show many organisms, so much so that the pathologist or the dermatologist is overwhelmed by a sea of red. But in that part of the world, the continent of Africa, most physicians don't do any testing whatsoever. It is a clinical diagnosis. And there's no good treatment. Treatment was basically surgery or prayer, tincture of time, and hope for the best until about 10 years ago, when the World Health Organization actually identified 2 good antibiotics, streptomycin coupled with rifampin, as treatment for it. Now, one requires a poke, it's given intramuscularly, so then it was replaced by rifampin and clarithromycin, and that combination of therapy actually helped to resolve the disease in many affected individuals. The third group of organisms is what I refer to as the rapidly growing mycobacteria. Rapidly growing because on culture, they grow very quickly, within 2, 3, 4 days. They don't produce pigment on culture, but they do grow very rapidly, hence the name rapidly growing mycobacteria. Now, these organisms have received a bit of notoriety in the last 10, 20 years, primarily because they are an accompaniment, an after-fact of 3 conditions. I think I'll focus on 3. One is they often follow surgery. Particular surgery, cosmetic surgery, meaning surgery of the face, facelifts, for example, eye surgery, following fillers. And secondly would be breast surgery in a woman, either reduction mammoplasty or augmentation mammoplasty. It's often a close accompaniment of the surgery. Fortunately, not that often, but when it occurs, it produces an ill patient, fever, cellulitis, paniculitis, and the organisms that are responsible are very resistant to treatment. So a physician and ID internist would require at least 2, sometimes 3, sometimes 4 antibiotics to address the infection and to turn the corner, so to speak. Number 2 of note would be tattoos. It's linked with tattoos. In the States, approximately 20% of the adult population has at least 1 tattoo. I don't think that number is quite as high in Europe or the UK specifically, but I wouldn't be surprised if it were. And with the presence of tattoos often occur reactions, often thought to be allergic reactions, and they affect about 10 to 30% of all patients with tattoos. But if you have a persistent reaction in a tattoo and you've thought about allergic contact dermatitis and it's not responding to topical corticosteroids intralesional corticosteroids, then think of an infection. Do a biopsy. If the biopsy shows a granuloma, obtain a culture, and if you grow an organism, bingo, you have a rapidly growing mycobacterial infection in the site of the tattoo. And with the proliferation of tattoos, probably around the world, I know in the States, this is not going to be an anomaly. This is going to be a rather common occurrence. And lastly would be the likelihood or the potential likelihood of rapidly growing mycobacterial infections or any mycobacterial infection in the face of biologic therapy. And we know biologic therapy is now become rather nouveau for the treatment of psoriasis, and most patients who receive a biologic product, agent, are required to obtain a TB test to be sure they're free of TB, and then periodically to be sure they are free of TB. Well, tuberculosis is certainly a valid thought, but our ID colleagues have shown us in the literature that non-tuberculous organisms, specifically some of the cutaneous pathogens, the rapidly growing organisms, as well as MAC, which is M. avium intracellulari, which is primarily a pulmonary pathogen, are just as common. The rapidly growing organisms occur with twice the frequency that tuberculosis does with biologic therapy. And pulmonary infection with M. avium intracellulari occurs with the same degree of frequency as M. tuberculosis. So these are important organisms to dermatologists, to pulmonologists, to our ID colleagues. We should be aware of them, we should be attuned to them, we should have an open mind. Fortunately, we don't encounter them that often, but they are not to be forgotten. They surround us. These mycobacterial organisms are in the environment. They are ubiquitous. We encountered them this morning when we took a shower, not necessarily together, but when we took a shower, we brushed our teeth, when we ate food, we washed our hands. They don't usually produce illness because we're hardy, healthy individuals, but they are all around us. And sometimes they are unwelcome inhabitants, and sometimes they anchor themselves in the skin or the lungs elsewhere. And we as dermatologists, I think, should be aware that they are a distinct possibility, especially when we see something that just doesn't sound right, smell right, look right, and doesn't respond to conventional therapy or the conventional approach to differential diagnosis and treatment. So that's it in a nutshell. That's 30 minutes condensed to about 4,
that's
maybe
brilliant.
5. No, it's not, but I tried.
Thank you so much.
Thank
Pleasure
you.
to talk to you.